today's webinar. Let me extend a warm welcome to you on behalf of the partnership and PANCAP's director, Mr. Derek Springer. Before we start, a few housekeeping points to note. Everyone's mics are muted. If you do have questions as the presentation progresses, please note them in the sidebar. Following the presentation, there will be a question and answer segment. So please type your questions in the comment section as you have them. Finally, the webinar will be recorded and shared on the PANCAP website, the YouTube channel, and social media platforms for the benefit of the greater partnership. Our presenter today is Dr. Natalia Largaespada Beer, a medical doctor with a master's degree in sexual and reproductive health. She has worked for the Ministry of Health in Belize since 2003 in maternal and child health. She's responsible for evidence-based recommendations to improve policies and programs through design, implementation, supervision, and monitoring and evaluation in the maternal and child health portfolio. In this role, she supports sexual and reproductive health and rights promotion, information, and services to targeted populations, including the prevention and control of cancer for cervix, breast, and prostate. With that, I'll turn it over to Dr. Natalia to share how the HPV vaccine was introduced in Belize.
Thank you very much, Elizabeth, for that introduction. I wowould like to first thank CARICOM and Dr. Singh for allowing Belize to share our experience and introduction of HPV vaccine. The results achieved so far is a collaborative effort between traditional and non-traditional partners in health. So an outline of the presentation is a quick overview of the program in Belize for the prevention of cancer of the cervix, the process that was followed for the introduction of the HPV vaccine, and then we close off with lessons learned and challenges from the introduction of the HPV vaccine. So Belize, as we all know, it's part of the Central American community as well as the Caribbean community. And we participate in the different coordinating bodies in both subregions, for example, CARICOM, COMISCA, SICA, and RESCAD. Belize have a population of almost 400,000. According to the Statistical Institute of Belize, with the mid-year estimate population for 2017. And we have an area of 8,867 square miles, and the official language is English. We are considered a country of upper middle income economy, which makes it difficult sometimes to access funds for social sector projects. We have 6 districts. As you can see there, Belize is the largest with 80% of the population living in urban settings, and Toledo with 80% of its population being rural. Also, Toledo have the highest poverty index, and the majority of its population is indigenous. With different ethnic groups, according to the last census, 53.9% mestizos, followed by Creole, Mayan, and Garifuna. So we are a diverse country when it comes to ethnicity. For the program overview, I will be reflecting a bit on the policy and legal framework that guide the work for the prevention of cervical cancer, speak about the National Committee for the Prevention of Cervical Cancer, what have been done at the level of norms, program management, and the revised screening strategies that we're implementing currently. At the policy level, we're guided by the Sexual and Reproductive Health Policy that was approved in 2002, and specifically focusing on reducing reproductive tract cancers and improve adolescent health with the introduction of the HPV vaccine. At the norm level, the National Cervical Cancer Prevention Committee, we work together with local partners and international partners in updating the clinical guidelines and procedure manual based on the World Health Organization guidelines for screening and treatment of precancerous lesions for cervical cancer prevention. Our local partners are the different stakeholders within the Ministry of Health, the Belize Cancer Society, the Belize Family Life Association, which is affiliated to the IPPF, the National Health Insurance from the Social Security, and local experts from the National Referral Hospital, the Carl Richner Memorial Hospital. International partners that help us in updating the guidelines is JAPIGO, the IPPF Western Hemisphere, the Pan American Health Organization, and the IUCC. In regards to program management, a strategic plan was developed for the period 2016-2021. We also develop our operational plans, and we do have a monitoring and evaluation plan in place for the cervical cancer prevention and control program. In following the recommendations from the WHO and looking at the resources that we have currently and some gaps in the provision of services, we decided as a group to invest in establishing the visual inspection with acetic acid as a preferred screening method. We do have some issues with the pathology department for the country where the pap smears are read. So to improve the access for women and the early treatment for cases diagnosed in early stages, then we have trained persons in visual inspection with acetic acid. So we do have a combination of pap smears and VIA that are being done. We also have cryotherapy and LEAP services. So we are following the recommended guidelines based on the resources that the country have. So we have so far trained persons from 10 different clinics that are providing screen and treat services. This is visual inspection with acetic acid. They were trained also in the provision of cryotherapy, and we also have access to LEAP services. And we are finalizing the procurement process for portable colposcopes that will help the staff at the local level, especially in rural communities, to access technical assistance from local experts, carrying the services closer to home. For VIA, we are targeting females 25 to 49 years, although the guidelines from WHO recommends 30 to 49. I will share with you a bit in the presentation why we did move the threshold from 30 to 25. So we are targeting 25 to 49 years. I must recognize that Belize Family Life Association was the first to introduce the VIA in Belize as a program targeting women at risk, and they help us to source funding from the IPPF Western Hemisphere for the training that was done for these persons working in 10 clinics. So as you can see on this map, every district have access to VIA, cryotherapy. At the level of the regions where we have OBGYNs, we have LEAP services, and colposcopy is also available, and surgical procedures. So we have a total of 4 hospitals countrywide providing these services. When it comes to just VIA and cryotherapy, these are the districts that have only community hospitals like Corozal, San Ignacio, and Toledo. And we are in the process of training the staff for our next 10 facilities to provide VIA and cryotherapy. The rest of the facilities, because they do not have trained personnel nor the equipment for the provision of cryotherapy, they are still providing pap smears. So the preferred method currently that we are promoting is the VIA for women 25 to 49 years. We have utilized the data coming from the Statistical Institute to define the target population by district. We have the data by urban and rural communities. So this is facilitating the monitoring of the coverage of the services that we have so far. The services are not provided only at health facilities. It is also provided during mobile clinics and health fairs. We make much of any type of gathering where we can offer this service. We're targeting women that have first-time screening service in life, or women that in the last 3 years did not have access to screening services. So the criteria for first time is first time in life, previous screening within the last 3 years but no result given is considered not having access to services, and first screening since 3 or more years. For women with HIV, the recommendation is for yearly screening. This is an example of monthly report from one clinic. As you can see there, we have the data separated by HIV negative and HIV positive women, or women with HIV unknown status. The target is 25 to 49, so we do collect data from the different age groups. In this specific report, 52 women were screened. 50 of them was first time in life or in the last 3 years, with a 100% single visit approach, meaning 5 women were found to be VIA positive with a lesion that could have been treated with cryotherapy, and they got the cryotherapy treatment. So the staff is doing a wonderful job and trying to offer the services to women who need it more. This report does not reflect how many women they came in contact that did not need a screening at the moment when they were seen. So that is a data that we need to collect also, so that we can show the full picture of women accessing services. The plans for 2018 is to continue with the training. We have an offer from Salud Mesoamerica Initiative and the Rotary Club. So we are working on that currently. We had a partnership with Rutgers University, and they have completed a needs assessment of the program. And this will help us identify current gaps that we are facing. And we are in the process of procuring pap smears, considering the problems that we are facing at our national pathology lab. We are working with ClearSight for the establishment of liquid cytology, but we are still in the process of establishing this methodology for screening. HPV screening is there in plans, but in the near future, probably we're still looking for a source of the testing at an affordable price. So I'll walk you a bit through the process that we followed for the vaccine introduction. In 2006, we had a program needs assessment that was done by CAREC, and we look at the different gaps, and the most important aspect was to address the issue of the turnaround time. So the country invested in providing the automated slide stainer, and that reduced the turnaround time from months up to 6 months or more to 2 weeks. Currently, we are now in process of procuring a new automated slide stainer so that we can improve the turnaround time that currently is about 2 months. In 2007, we had the opportunity to conduct a seroprevalence of HPV among women. 463 women from Belize City were screened, and We had a donation from the Gene Corporation, 20 different type of HPV, and out of the 20, we tested positive for 18. So out of all the positive cases, 18 different type of HPV viruses were diagnosed as positive. So you can see there that the overall prevalence of the HPV in the population studied was 15.6%. And by age group, as the literature says, younger women are the one them that have the highest HPV prevalence rate. And we can see there that also younger women are the one them that have higher rates of HPV 16 and HPV 18. In 2011, the private sector started to provide the HPV vaccine. Due to economical barriers, well, the uptake is not high. They still provide the HPV vaccine in private sector. We try to collaborate, offering a lower price of for the vaccine. So, but still, the uptake in private sector is a bit poor. In 2013, we had a cost effectiveness analysis of the HPV vaccine introduction, and this was with support from the Pan American Health Organization, where it was demonstrated that the investment in introducing the vaccine outweigh the investment of dealing with a patient with cervical cancer, especially in advanced stages. Review was done on cancer in Belize for the period 2011-2012, and this was done by Dr. Aisha Andrew, who was our national epidemiologist at the Ministry of Health. The data shows that out of every 4 persons with cancer in Belize, irrespective of age and sex, is a woman with cervical cancer, followed with cases of breast cancer. So we know that cervical cancer and breast cancer are public health problems that we need to address more aggressively. This data was utilized for the reduction of the age group for the screening. So we moved from 30 to 49 to 25 to 49 for Belize. So those are using the data from this report. We did a quick and dirty survey and acceptance of the HPV vaccine among women accessing vaccination services for children 0 to 5. And this was done during Vaccination Week in the Americas in 2016. As you can see there, women heard of cervical cancer, but only about half of them heard about the vaccine. A mixed report on if the vaccine is helpful, higher in one region and lower in the next. And the uptake was high in both districts. And if they would authorize their child to receive the vaccine, the response was pretty high. So this was done before the introduction of the vaccine. So once we decided to introduce the vaccine into the national vaccination schedule, then we look at, okay, where the services would be provided. So the national committee reviewed the data available and the evidence available. And since school-based programs are proven to be more effective than facility-based or community-based program, then we decided to have the program for the delivery of the HPV vaccine at schools. We're using the quadrivalent with the HPV 16, 18, 6, and 11. Then the decision was the age group. If we are considering children between 9 and 13, then we needed to decide, okay, out of 9 and 13 years, if we only can afford for one cohort of girls, what age group? But before that, we started with the mapping of the stakeholders in preparation for the introduction of the vaccine. And we identified Key stakeholders being religious leaders, the Ministry of Education, since we decided for it to be a school-based program, the media houses, the civil society organizations, healthcare workers, and community health workers. And most importantly, parents. So these were all the different stakeholders that we consider was important for us to speak with them before the introduction of the vaccine. So the plan was to vaccinate girls 10 years old. And when we went to the schools, we thought we would find girls 10-year-old in standard 4, but we find a mix of girls 10 years and 11 years old in standard 4. So the message now is we vaccinate all girls in standard 4, irrespective of the age that they have, not to discriminate anyone that is in standard 4. The first procurement of the vaccine was done by the Belize Social Security Board through the PAHO Revolving Fund. We designed a parental consent form with an accompanying information sheet that was vetted by our Attorney General Ministry. And we have a census and reporting forms of the girls to receive the vaccine. And because I'm working with adolescents, any procedure of any type cause anxiety in them, and the recommendations of providing the vaccines, we make sure that when we spoke with the parents, we encourage them that the girls have breakfast on the day of vaccination. It's a vaccine that is still controversial, but because of that nature of controversy in the community, is one of the vaccines that have been more studied. So we wanted to remove all the possible causes of a reaction that may not be necessarily from the vaccine. And that is why we consider important to share with you all that we do recommend parents that on the day of the vaccination, the girls have breakfast at home. And to ensure that for those girls that did not have breakfast at home, the staff is providing a snack while they're waiting for the vaccine. They get a snack, a banana, a fruit, or a juice while waiting on the vaccine to be administered. So, as I was mentioning earlier, what grade would we look for girls to be vaccinated? So, we use the statistics from the Ministry of Education. As you can see, if we would set up our program to give girls in standard 6, like how Mexico is doing currently, at standard 6, we have a dropout rate of 19% according to these statistics from Ministry of Education. So this is the rationale behind deciding for girls in standard 4. 4,450, highest number compared to the other grades, standard 3, 4, standard 5, and standard 6. So moving into the lessons learned, while we were addressing the issue of the introduction of the HPV vaccine with the different leaders in the community, it was mentioned that we need to ensure that the population understands that this is just one more of the preventive interventions throughout the life course. So for example, for adolescents, we are providing multivitamins, we provide iron and folic acid. We do have dewormings, tetanus and diphtheria vaccine, health education, and HPV vaccine is just one more of the preventive interventions. Our next lesson learned is that this cannot be done only by the Ministry of Health. We need all the different partners that are working towards reducing the prevalence of cervical cancer. So we have at the launch that was done for the HPV vaccine introduction, we have an OBGYN oncologist that is working only in private sector. We have the Ministry of Health represented by the Director of Health Services and myself. We have the Belize Cancer Society, who is spearheading the civil society participation in reducing cervical cancer. We have the Chief Education Officer, and we have a representative from the church. So definitely, um, we need to have a multi-sectoral approach when it comes to protecting girls against HPV infection that can lead later on to cervical cancer. Our next lesson learned is we need to be respectful. We are working with established institutions, and as such, we need to respect the hierarchy that already exists in these organizations. This is just to showcase that the president of the Belize Cancer Society and a representative from the Ministry of Health went to each one of these sessions. In radio, I can observe the number of persons that participated in each one of these sessions. So this is just to show an example of a church that we work with. We met and did a full presentation just for the bishop. Then we had a second meeting and we met with the bishop and the country school manager. Then we had a third meeting with the bishop, the school manager, and the district managers. And then after that, we had larger groups sharing the information that was necessary. And at all the different levels, we got full support with the recommendation that who needs to give permission for the girl to receive the vaccine is the parent. So that's a step that we cannot avoid, meeting with the parents to get their okay for the girl to receive the vaccine. But this is a lesson learned that I think it's pretty good to share with other colleagues. Transparency. When we talk about transparency, a lot of information is there available on HPV and cervical cancer. When we started the round of trainings for the healthcare workers and for other stakeholders, people were talking about, oh, it's a new vaccine. So it's a new virus. So we went and we researched a bit on the history of HPV and put it together in a slide, just sharing that it's not a new virus. It's just that, and it's not a new vaccine. It's a vaccine that exists 10 years before. It's just that we did not have the resources to um, introduce it into the national vaccination schedule until now. So this worked out pretty good. So we were updating the presentations based on questions and concerns, and it went pretty good. Our next lesson learned, we need to train our media personnel on the issue at hand. In this case, we trained them on HPV. So they received the same training we gave to healthcare workers. We gave it to the representatives of the different media houses. And this allowed them to receive the most up-to-date information that they can share with the population through the different news items that they can produce. So this worked out pretty good for us too. With radio and TV talk shows, we went to each and every one where we were invited to. And a lesson learned from TV talk shows is to train the host before the show, because then they would break down the message to the community and request that the guests just further explain a specific point. So we find this to be very helpful. We had our healthcare workers. We trained them for 8 hours in preparation for a 10-minute presentation to parents. So we built a standardized poster with key information on how to start the conversation on HPV with parents. This is to remove the barrier of not having a PowerPoint, a laptop, not having access to a projector in a community or a school, then this poster is used for guiding the person that is presenting the information, especially to the parents, to give them the opportunity to ask all of their questions related to the vaccines. A next lesson learned is that whenever we have an opportunity to provide evidence that is available on the vaccine, we welcome these opportunities. And this does not exclude the anti-vaccine groups. When the vaccine was launched, we did have, I would say, approximately 2 weeks with intense activity by the anti-vaccine groups, and we used the opportunity to share the evidence available. So this is a lesson learned that we need to be ready to provide information to whoever is requiring the information. Some of the challenges that we face, we decided to introduce the vaccine, and we were so focused on sensitizing the different stakeholders for it to happen that we lose track of the social mobilization, and really and truly we did not have any funds for social mobilization. But we realized that HPV vaccine cannot be promoted through a flyer or a brochure. Parents and girls receiving the vaccines need the opportunity to have a face-to-face conversation on the HPV vaccine. We have 6 districts. For the first round, we have 3 districts with almost 80% coverage or more than 80% coverage, and we have 3 districts below 80% and some very low coverages. But going back to the drawing board, we realized that the sensitization process was not followed duly, and we do recognize it because the experience is out of every 10 parents that have the opportunity to receive the information on HPV vaccine, 9 out of 10, if not 10, accept for their child to receive the vaccine. So it was a challenge, but I think it more than a challenge, we come to that realization that it's face-to-face conversation that needs to happen to be able to reach the girl and protect them against the HPV infections that can lead later on to cervical cancer. We work with the Ministry of Education. They provide us with a list of all the schools countrywide per community, and we have a large number of schools with a small amount of girls in standard 4. So we had to make a decision. So we decided that we would run campaigns, school-based campaigns for schools with large amount of girls in standard 4. And for those schools with small amount of girls, then we would cover them during mobile clinics. The Ministry of Health in Belize provides mobile clinic services every 6 to 8 weeks to all communities. So we have that there as a resource to reach these girls, to reduce the cost of the administration of the vaccine. We had some issues with the timely supply of vaccines, but we overcame it and it worked out pretty good. We did not have to move our launching date, which is what we were worried about, but it worked out pretty well. The meeting with the media houses, we did it 2 days before the launching of the vaccine, and we requested that there should be an embargo on any article news regarding the HPV vaccine until after the launching. So they were very supportive in this aspect. Sometimes we face difficulties, but once we are focused on the results that we're trying to achieve, we had the Hurricane Earl that made landfall in Belize, and we finished our strategic plan. The final review was 2 days before the hurricane hit Belize. And we also had a 2-week teacher strike in the middle of the sensitization that was ongoing with parents just before the vaccination, and we did not stop any of those activities. So this is just to showcase that we need to be focused on the result, and there are situations that may arise, but not sufficient in the way to stop a process that is ongoing. So in conclusion, we do have problems with cervical cancer in Belize for the period 2013-2017. The incidence rate of the diagnosed cases is 38.8 for females 15 and older. Deaths due to cancer of the cervix for the same time period. The mortality rate is 23.7 among females 15 and older. We introduced the vaccine since October 2016. It's currently being procured by the government of Belize. The coverage by school year for 2016-2017 was 58.8%. And for the school year 2017-2018, the coverage is 62.4%. The preferred screening method currently that we're utilizing is the VIA, visual inspection with acetic acid, for women that meets the criteria. We know that the coverage is insufficient as the staff is only providing the services for 1 day a week, and this is a barrier that we need to remove. Ideally, we should have the service every time the woman reach to the facility, so we are working on this. We have a target population defined by district in both urban and rural communities. We need to do some investment in the pathology department for the Ministry of Health in both capacity building and equipment and supplies. And we need to continue with the expansion of the CN3 clinics, which we are working with currently with Salud Mesoamerica and probably with the Rotary Club here in Belize. And we're happy for this opportunity for sharing our experience. We develop several different types of materials, information sheet for parents, a consent form, educational poster for parents, and we are willing to share our PowerPoint presentations and educational videos that the country produce for prevention of cervical cancer. We have the HPV introduction plan, our reporting forms, and the draft letter that the Ministry of Education sent to parents inviting them to for their children to receive the HPV vaccine. So I would just like to close off by saying that it is a collaborative effort between all the different stakeholders, traditional and non-traditional in health. We do have some difficulties, but we have the support from the government of Belize, the Ministry of Health authorities, the Belize Cancer Society, the Social Security, the Belize Family Life Association, the different organizations at community level, like the village councils. We need to do more work with them, but it's an effort that it cannot be achieved just by the Ministry of Health. Definitely not. And it's a result that will improve the lives of girls and women and will reduce the out-of-pocket payment for services in the future and will reduce the cost for the investment in health. So we need to make it happen, but we need everyone to be a part of it for it to happen. So I thank you very much, and if you have any question, I am happy to answer.
Thank you so much for that informative presentation, Dr. Natalia, and for allowing others to benefit from the materials that you've shared and developed for this. We had a couple comments and questions come in about that specifically. So the email address is there to request those materials from Dr. Natalia. I'm pleased to open it up for the question and answer portion of the webinar. So please do send your questions through the questions portion of the sidebar. And I guess while we're waiting for attendees to send any questions they may have, from me, I appreciate you including information on how you shared pertinent information with anti-vaccine groups. I'm curious, where you initially met with a lot of myths and misconceptions on the vaccine itself before sitting down face to face with stakeholders?
Yes, we utilize the existing myths that are documented and make sure that we include all of the information in our presentations. And I can tell you we started probably with 50 slides and we end up with about 80 slides.
Wow.
Every session was improving the presentation. So presentation from day one is nothing close to presentation the last time we met with stakeholders. Every question was an opportunity to improve on the presentation. So what happened was that we had a lot of questions at the beginning, and at the end, we did not have much questions from the participants because we tried to include all the information. I think the one that we enjoyed more was whenever we heard a comment, oh, it's a new virus, because in that time when we were hearing about Ebola virus and other virus circulating, so people were saying, oh, it's a new virus. It's not a new virus. So we use it to learn also the history of HPV. So it went pretty good.
Great. We have a question. Belize has been a guide to the countries within the Caribbean region on the introduction because your country has had one of the best introductions thus far. Did you have any kind of support from PAHO?
The Pan American Health Organization, when we procure the vaccines through them, they have certified and pre-qualified vaccines. So our first choice is to procure through PAHO. So they offer us that opportunity. The Pan American Health Organization also provided technical assistance in the updating of the procedure, the clinical guidelines and procedure manual. Yes, they were there with us, providing assistance.
Great. Someone is curious if you've had any reports of any serious adverse events from the Gardasil vaccine. If so, what were some of those?
Yeah, we apply all the preventive recommendations, like having the girls sitting down while applying the vaccine, observing the girls for 15 minutes before letting them go back to the classroom. And we added the issue of avoiding the non-breakfast. And we only had 2 cases of dizziness without losing consciousness. So I can't tell you if in detail if was an issue of not having breakfast or no, or was secondary to the vaccine. But No loss of consciousness. Just a bit dizzy after receiving the vaccine, and that was it. Just took
Great,
it. Yeah.
thanks. Someone else is asking, is there value in making the vaccine available to young MSMs?
The issue of the vaccine is the recommended age groups for the region of the Americas is 9 to 26. In Australia, for example, they use it up to 45 years. And the problem, well, not the problem, but one of the issues that people need to be reminded of is that you can receive the vaccine today if you fall into that age group of 9 to 26. But if you already have a process ongoing with 16 or 18 HPV type, then probably the vaccine will protect only against the one that you did not come in contact with. Meaning, if we provide the vaccine to a girl or a woman that is have contracted the 16, then she will get protected only against 18, and vice versa, or other types that are cancer causing. So that's why it's recommended in early ages when we can be more assured that the girl probably haven't had any sexual contact, although we don't ask that question none at all, because that is not important. We just want to provide the vaccine for their protection. So it's a, I would say, a win-win situation. In the case of the MSM, of course, it will help them to reduce penile cancers, cancer in the throat. But again, the issue of have they come in contact with the virus before the vaccine? So that would be my response on this.
Thank you. If anyone has any last minute questions, please send them through in the next minute. Otherwise, we'll be winding down the webinar. While we wait, I'll wait another minute, but while we wait, you will receive a short survey. I encourage you to provide feedback on this webinar. It will help us to better serve you. I'd like to, on behalf of PANCAP, the director, Mr. Derek Springer, and the participants today, thank you to our presenter, Dr. Natalia Beard, for investing in the webinar and sharing your knowledge and experience with the partnership. And thank you to all the participants who have joined us today. Just as a reminder, the webinar was recorded and will be posted on the PANCAP's website. And please do join us for future webinars. I'm not seeing any other questions come in, so thank you everyone for joining today, and have a great rest of your day.
Thank you very much.
Bye-bye.